Welcome to the Case of the Month. The last two cases involve pathology related to the carpal tunnel, which can be reviewed in the Community Hub and ultimatemsk.com. This current Case of the Month evaluates a painful dorsal wrist mass with the dynamic capability of ultrasound solidifying the diagnosis. Let's get started. A 54-year-old avid horseback rider presented with a painful left dorsal wrist mass. Her riding position often requires her wrist to be positioned in dorsiflexion. Approximately 1 year prior, she developed intermittent dorsal wrist pain during periods of frequent riding. Over several months, the pain became more constant and she developed a slight bump on the dorsal aspect of the wrist. The mass has slowly increased in size and remains painful. Radiographs were obtained and showed mild degenerative changes. A diagnostic ultrasound was requested. On physical examination, the patient had an approximately 2 by 2 centimeter palpable subcutaneous mass located over the radiocarpal joint, just ulnar to Lister's tubercle. There was no erythema, but the mass was moderately tender to palpation. Wrist dorsiflexion was limited to 50 degrees, with pain at the end range. Please refer to the dorsal wrist protocol and anatomy and live scan of the dorsal wrist lessons in the wrist module for details regarding my scanning protocol, as well as the sonoanatomy and scanning technique of the dorsal wrist structures. When evaluating the dorsal wrist compartments with ultrasound, I generally survey each compartment in the short axis transducer orientation and include long axis images when clinically pertinent. The ultrasound image is a short axis view of the 3rd through 5th dorsal compartments in our patient. As a brief review, the illustration on the right is an enlargement of these 3 compartments. The bony cortices of the radius and ulna, as well as the distal radial ulnar joint, are clearly viewed. The 3rd dorsal compartment contains the extensor pollicis longus tendon and has an important relationship with Lister's tubercle, which in this case has a saddle-like morphology. The 4th dorsal compartment contains the extensor digitorum communis tendons to each finger and also includes the extensor indicis proprius tendon, which accompanies the extensor digitorum communis tendon to the index finger. Additionally, this compartment houses a branch of the posterior interosseous nerve, along with its named artery and vein. The 5th dorsal compartment contains the extensor digiti minimi tendon and is easily located over the distal radial ulnar joint. The extensor retinaculum of the 3rd through 5th dorsal compartments is interconnected. The radial side of the extensor retinaculum for the 3rd dorsal compartment has a bony attachment to Lister's tubercle, while its ulnar side connects to the retinaculum of the 4th dorsal compartment. The retinaculum of the 4th dorsal compartment has both supratendinous and infratendinous components, each anchoring onto the radius. The retinaculum of the 5th dorsal compartment arises from both tendinous components of the 4th dorsal compartment without direct bony attachments. Returning to our case, the tendons of the 4th dorsal compartment are labeled with a contralateral comparison view shown on the right. In our patient, the 4th dorsal compartment tendons are markedly enlarged, irregular, and demonstrate partial thickness tearing. Additionally, the extensor digitorum communis tendon to the small finger is absent, making the extensor digiti minimi tendon solely responsible for small finger extension. The configuration of the extensor tendons to the small finger varies among individuals. Doppler imaging reveals scattered vascularity, indicating a possible inflammatory component. The short axis image is now a proximal to distal cineclip. As the scan progresses distally, the extensor retinaculum of the 4th dorsal compartment comes into view and appears thickened. To confirm retinacular thickening, I recommend obtaining a contralateral comparison view as shown in the image on the right. Notably, the thickening involves the entire fourth dorsal compartment retinaculum and closely resembles the appearance of a stenosing tenosynovitis of the first dorsal compartment, commonly known as de Quervain's tenosynovitis, as demonstrated in the image on the right. The sonographic findings of stenosing tenosynovitis include retinacular thickening, with or without vascularity on Doppler imaging, varying degrees of tendon pathology, including hypoechoic thickening, altered fibular echotexture, partial thickness tears, and hyperemia. A common feature of stenosing tenosynovitis is that the tendons have a more rounded or stenotic appearance due to the relative inelasticity and narrowing from the retinacular thickening and fibrotic changes. Additionally, dynamic imaging often reveals varying degrees of restriction of tendon motion through the retinaculum. As the short axis cineclip continued towards the fingers, tendon enlargement with partial thickness tearing becomes readily apparent, with the tendons highlighted and labeled. Scanning further distally, the tendons begin to normalize distal to the metacarpal phalangeal joints. In this case, dynamic imaging in the long axis view is important for establishing the diagnosis. The ultrasound image is a long axis view of the fourth dorsal compartment extensor retinaculum with a contralateral comparison. Distal is to the left. The involved side demonstrates a thickened retinaculum compared to the asymptomatic side. During dynamic active finger extension, the extensor digitorum communis tendons are viewed impinging against the proximal edge of the extensor retinaculum, restricting their movement through the fourth dorsal compartment. Dorsal wrist impingement is an uncommon but well-described diagnosis. In this case, the short axis ultrasound images reveal findings consistent with stenosing tenosynovitis, including retinacular thickening, tendon abnormalities, and a characteristic rounded appearance of the tendons. The differential diagnosis for tenosynovitis of the fourth dorsal compartment includes an inflammatory arthropathy such as rheumatoid arthritis, deposition disease such as gout or calcium pyrophosphate deposition, infection, and repetitive microtrauma. Importantly, the dynamic capabilities of ultrasound effectively demonstrate restricted motion and impingement of the extensor digitorum communis tendons against the extensor retinaculum. Given these findings, the patient was referred to hand surgery for surgical consultation. In summary, knowledge of the sonoanatomy of the dorsal compartments, recognition of the sonographic findings of a stenosing tenosynovitis, and dynamic imaging nicely reveal the findings of wrist impingement involving the fourth dorsal compartment. I invite you to share your thoughts on this case by posting a comment in the community hub at ultimatemsk.com.